COVID-19 in children and what we know so far. And I would say that children, the study of children in COVID-19 has been quite limited, even to this day. We're kind of 2.5 years into the pandemic. I will speak a little bit about transmission in children and their immune responses. And I'll touch a little bit about the long-term consequences about COVID-19, so particularly MIS-C, which is a severe inflammatory syndrome, and long COVID, particularly in children. And then I'll kind of touch at the end about vaccination, because I think vaccination is an important aspect, not only in adults, but in children, and I think will become more important. Okay, so the changing epidemiology, I just put this graph up. This is quite a recent data slide, and it's really just to show you the lines here are what's important. What you can see here is they've had a number of waves throughout the pandemic, and really the highlight here is what's happening.
Okay. We can hear you.
Hello, can you hear me now?
Yeah, I can hear you now, but you went up for a bit just now.
Oh, okay. So I was just making the point that we've had a significant increase in cases here in January 2022, and this is largely driven by the Omicron variant, as everyone is aware. And that's really occurred right across the globe in all the different kind of regions of the world. And at the bottom here, this is really just to emphasize the fact that this red peak here that we're seeing or starting to emerge at the start of this year is due to Omicron. And so that's kind of where we're at. And I think even now in June, we're probably completely dominated by Omicron and its various subvariants. Okay, I think there's a bit of a lag. Hang on. Has both slides disappeared just now?
Yes, Dr. Paul, the slide disappeared.
Yeah, okay, just hang on a second. Not sure what's happening. Okay, that should be back. Okay, hopefully that's fine now. So I just wanted to highlight the cases here. I've put a couple of examples here of countries of Australia and Malaysia, of course, of relevance, but also the US and Portugal. And I just wanted to highlight the emerging cases that we're seeing. And it's pretty clear that we're nowhere near the end of this pandemic. And what I've included here is Portugal, because Portugal is an interesting setting where there's been a very high rate of vaccine use. And you can see here, despite that, they've had a really significant surge in Omicron infections. And this is due to the subvariant BA4 and BA5. And it's interesting to note that in places like Malaysia and Australia and elsewhere, we have not seen a significant proportion of cases due to those subvariants. And so we're kind of a bit of a wait and see as to what's happening in terms of emergence of both cases and deaths. So it's a bit of a kind of sobering thought as we move through the current period. In terms of children, this is what it looks like. So this is a bit more encouraging data. What we see here is in the top panel, we see the level of admissions and cases in relation to children, and these are 3 European countries where there've been historically a high burden of disease. And the bottom 3 are the same in the same settings for adults. And of course, the main difference between these two groups are the vaccination status. And in adults where there's been a high vaccine uptake, you can see there's been a kind of decoupling, as they say, between admissions and cases. So that in the past, prior to vaccination, you'd see a huge number of cases, and that would follow with more severe disease, particularly hospital admissions and even deaths. But we don't see this anymore with adults, at least up until January 2022. We have lots of cases, but not a lot of severe disease. It's not the case in children, and we know in children, particularly the younger age groups where vaccination is not being used, in many places not approved yet, and so you're still getting this very close connection between cases and the more severe disease. And this is what I guess is one call for improving vaccination coverage in these groups. I put this slide in just for a bit of perspective because those that are familiar with infectious diseases would be familiar with bronchiolitis and particularly RSV. And RSV is another respiratory virus, very, very common, actually one of the most common viral infections in young children. But because of the social mitigation public health initiatives during COVID, we actually saw pretty much no RSV in that first 2 years of the pandemic. Once certain restrictions were lifted, we kind of started to get a bit of a peak, but kind of starting with an emergence of COVID as well. So important for this slide is that just to put into context, while COVID-19 is relatively less severe in children, maybe not so in terms of the levels of what we might normally see with other infectious diseases, it's actually now starting to be on the rise. And in fact, in Melbourne, we're right in the middle of our winter season, and we're seeing a huge spike in RSV cases now that we're essentially restriction-free. These graphs here, these big curves here, is what we used to see in terms of bronchiolitis prior to the pandemic. And bronchiolitis, as we know, is mostly caused by RSV. So we're still not at that level yet, but we are going to see that very soon. Now, in terms of COVID-19 in children, in terms of exposure, we know that this is rising, and we know that Omicron is everywhere, but particularly in children. And one way to measure this is through seroprevalence, that is measuring antibodies to the virus over time. And what you can see here is that from October 2020 right through to January 2022, you can see the rates of seroprevalence actually increasing, particularly even at a higher rate in children compared to adults. And that's due to I guess the more susceptibility of children, particularly the unvaccinated children, the younger age groups, to Omicron variant. And that's data from the US, but we also see a very similar data in the UK, in the various jurisdictions of the UK where exposure to the virus has actually increased quite a lot. So what do we know about COVID-19 in children? So we do know that children do get COVID. We know that in most cases it's very mild or asymptomatic even, and that severe disease is actually quite rare. Even now with Omicron, it is quite rare, although the data that we have with subvariants is emerging, and that kind of may be slightly different. Historically, children have not been the primary transmitters of SARS-CoV-2, and there's a lot of early studies looking at transmission among children, particularly in school settings, and really children were not the major drivers of transmission. Whatever transmission did occur in schools generally reflected the transmission in the community. So even today, where we have lots of community transmission due to Omicron, that is somewhat reflected in what's going on in the schools. And that has led to a lot of testing procedures happening within the school communities. And similarly, the increased number of hospitalizations due to Omicron does reflect the more widespread transmission in cases. So of course, you're going to get a lot more cases, and some of those are going to end up in hospital. And like I showed you that data from some European countries, we haven't yet seen a kind of disconnect between cases and hospitalization in children. Right from the start of the pandemic, there's been a number of different hypotheses put forward as to why children don't develop severe COVID-19. It's actually quite different to many other respiratory diseases. And I guess we kind of haven't really understood or confirmed any of these hypotheses, and they're kind of all emerging hypotheses even today. And I'll go through them in a little bit, the next slide. So importantly, severe COVID can occur, particularly complications, and I'll talk about this later in the seminar, particularly MIS-C. It does occur, but it's still very, very rare, and that's even in the context of these variants of concern, and that's somewhat reassuring because that's kind of what we're interested in, the more serious complications of COVID-19. So in terms of some of these hypotheses, and there are many hypotheses, and if you do any searching of literature around this, there's many different kinds of theories as to why children are less susceptible to COVID-19 and in particular severe COVID-19. And this is from a paper from last year. We put forward a number of different hypotheses, and the diagram here is really, I guess, the most common ones. We know that the virus binds to host cells, particularly in the upper respiratory tract and in the lung, through a receptor called ACE2. And it was thought that, or postulated that one of the mechanisms is that in children they have less ACE2 expression, receptor expression, and therefore less viral binding. That has more or less there's been many studies showing a positive relationship and also a negative relationship. So this is not really confirmed yet. Another hypothesis was around exposure to cigarettes and air pollution. And of course, that might be true in some societies, but we know there's many other regions where there's a lot of air pollution, and that might not be necessarily separated from children. So we know that children can be exposed to lots of indoor air pollution, for example. There is a concept also known as trained immunity, and this is where you might get a vaccine, particularly BCG vaccine. This is the vaccine for TB, which induces certain changes in your immune response that allows you to respond to lots of other pathogens, including SARS-CoV-2. This is called non-specific effects. There's been a lot of research done on this, and importantly, there are studies ongoing to look at the effect of BCG vaccine on SARS-CoV-2, and that data is still actually to be published, but that's another theory as to why children may be protected, and possibly even adults who are receiving BCG vaccine. Another prevailing view was coronavirus infections, and coronavirus is what causes the common cold, and we know that children get lots of these coronavirus infections in early life, and it's thought that prior infection with a number of different coronaviruses might actually help them limit the disease caused by SARS-CoV-2. And again, there is evidence for and against this hypothesis. Other major hypotheses I've put here are changes in endothelium and clotting functions, and we know that SARS-CoV-2 causes significant vascular damage, and that has been somewhat related to age. As you age, you tend to get more vascular problems, and that might be a target for the virus. And another common one is age-related immune system differences. Of course, we know that the immune system changes rapidly with age, and it might be that these changes influence whether you get more severe manifestations of the infection. So in terms of transmission and immune response in children more generally, what do we know? So as I mentioned before, that children are not the drivers of transmission, not the major transmitters of SARS-CoV-2, and that's really in any setting. Most cases that have been reported are generally adult to child, not child to adult, and it's not really child to another child. And so most of this work has been done, I would say, during the pre-Omicron settings. So we're still not clear about whether this is also true for Omicron, or there is some data that suggests this is much less for Omicron. Households, of course, are the major source of infection and still continue to be. And an early paper did show that children were only 4% of what we call the index case. That is the first case in a family setting. And so, as I mentioned before, schools and educational settings are not, and still maintain, not really the drivers of transmission. And that any transmission that does occur in schools really just reflects community transmission more generally. And again, this is prior to Omicron, and some of this data is now emerging for Omicron. We know that during Omicron period, there's certainly a lot more younger children being infected, and that's largely because they are not vaccinated. The vaccines are not approved yet in young children, although that is happening at the moment, particularly in those under 5. And so that is where you have the virus tends to find its way to those that are more susceptible, such as those that haven't been vaccinated. And so I think it's important to note that mitigation measures are still critical, particularly for those young children, because in a family setting or in a community setting, the virus will find, I guess, those that are the most susceptible, no matter what kind of environment that you might be in. This is kind of some recent data from Japan, and it kind of further illustrates this issue about transmission, because what this study did was they looked at children, and they looked importantly at children between 0 and 3 years of age. We're talking very, very young children. These are children that haven't been vaccinated, and this is where mandating things like mask wearing is not occurring. So these are children that are essentially exposed and can be exposed to the virus. And what we see here is that they've done a kind of an analysis of transmission in that age group across the various waves. And you can see here in the early wave, which was the Wuhan wave, from the Alpha wave to Delta wave and Omicron. And I kind of highlighted in the red box here the key bits of information. These are different, each row is kind of a different example of transmission. But what's important here is the numbers in brackets. And you can see from early on in the pandemic, the actual transmission in young children, okay, depending on whether it was a high risk contact or low risk contact, etc., was very, very low. It's probably less than 5% if you took an average here. But by the time we get to Omicron here, we see that this is much higher. This is around 40% now in some settings. So this is because children are now become target of the virus because of their lack of vaccine immunity, and also the fact that mask wearing in this particular this group is not really feasible in many situations. So to talk a little bit about the research that we're doing at MCRI, we kind of embarked on this study called FFX, which stands for First Few Hundred study. And this was developed very early in 2020. This was a WHO protocol. And this was really to understand what was the determinants and drivers of transmission and host response in a household setting. And what we did, actually, we took that protocol and we adapted it to include intensive biological sampling within that first month of transmission. So when an index patient, whether that was a child or an adult, was positive for SARS-CoV-2, the whole family then had a series of samples taken: blood, urine, swabs, saliva, and stool, and we're able to kind of really characterize extensively what are the various viral and host dynamics that might be driving transmission and disease. And so in this study, we had 26 families with what we call intensive sampling, with all of these different sample types. But actually, since then, we've actually recruited more than 150 families with long-term follow-up. And these are basically with swabs and blood samples. And so I'll show you a little bit about this data that we've been accumulating. Now, this first bit of data that came from this work was very, very interesting, actually, and has actually been quite important in some of the subsequent research that's been done globally. This was what we call family 1, and this was the very first family that was recruited into this study very early in 2020. And it was a very unique setting because we had a situation where, and I've got the timeline down the bottom here. It's a bit hard to understand here, but basically what happened was that the parents were from Melbourne. The family was from Melbourne. They went to Sydney for a wedding. This wedding actually ended up being a very well documented super spreader event. Many cases. And those two parents, they returned back to Melbourne unaware that they were infected, developed symptoms essentially as soon as they arrived back home. And within 7 days, they developed very, very significant symptoms. They weren't hospitalized, but quite serious symptoms. They tested positive. Both parents tested positive around about a week later. And it was around this time that their 3 children started to develop some form of symptoms, albeit quite mild. So 2 of the children, here you can see here, C1 and C2, had some symptoms. The 3rd child was asymptomatic. And over the course of this first month, we collected a whole range of biospecimens. And what we found was something really, really interesting. We actually found that despite the children being in very, very close contact with the parents, as you might expect, they were very young children, they actually repeatedly tested negative by PCR. So very high exposure. The parents were PCR positive, but the children were not. However, they actually all had evidence of exposure to the virus. And we know this because we measured their blood cells. We measured a range of different immune cells important for the virus, things like T cells, B cells, innate cells like natural killer cells, which are important for viruses, monocytes and dendritic cells. And what you can see here is that on a quick scan, no matter what these cells look like here, they're all following the same pattern, whether you're a child or an adult. And that suggested to us that the children, in fact, were exposed to the virus. They responded to the virus, but they just didn't produce a SARS-CoV positive PCR test for reasons at the time that we were not really sure of. And it was only until we started to do some further investigations by serology, and what we saw here was quite interesting. So it's really the red boxes that you should be looking at. And what you see here is that we have, on the top panel here, are the antibody responses in the saliva sample. So that's the mucosal system. And this is where the virus first comes in contact with the host system. In the bottom here is the blood or the serum levels of these antibodies. And what you can see here is I've highlighted in these boxes the responses in the children. And you can see that in all three children, there was a significantly elevated salivary IgA response. Not much IgG or IgM is what we would normally expect. Lots of IgA. And in those children that had the very high levels of IgA, actually, they did not seroconvert. They produced no evidence of antibodies in the blood, whether it was IgA, whether it was IgG, had a little bit of IgG, this is kind of borderline positive, and IgM. And it was actually interesting here because we could see here that, and you could see there's a couple of hashes here. We put those hashes there because that denotes the fact that the onset of the IgA antibodies actually coincided with resolution of their symptoms, particularly in child 1 and 2 who had symptoms. So we felt that the mucosal antibody response was very important for early control of the virus. And because they controlled the virus and cleared the virus very, very efficiently, much faster than in adults, they didn't produce a PCR positive test and therefore didn't produce an antibody response. And that was quite an interesting finding. We'll see in a minute, it actually was backed up by other data. This is what the data looked like from all the families in our study, and this was just recently published. And so what you can see here is on the left, that whether you're an adult or a child, in terms of what is driving transmission within a household, it was clearly adult had a much higher odds ratio of transmission if the adult was an index case, or a child. If you were a child, it had no effect. Of course, the CT value or the viral load, how much virus was in the system, has a major effect. So if you had a high viral load, of course, you had a much higher odds of having transmission compared to having very low levels of viral load. And all these other factors that we measured, whether they were symptomatic or not, whether they had various isolation methods in the house, or wearing a mask, for example, didn't really have much of an impact, probably because in a household setting, those things are very, very hard to do. When we looked at the correlation between the various things that we measured, so all the kind of immunological testing, the PCR testing, particularly in the swabs, but also in the stool and the saliva, actually we saw very, very high levels of correlation. And that suggests that there was a strong interaction between the virus and the immune system, as we might anticipate. So what we also found was, like that very first family, we found that across all the families in that cohort, if you had salivary antibody detected in your sample, you had a much lower level of seroconversion. These are among the children. Okay, only 20-something% actually seroconverted, compared to those that had presence of salivary antibody. If you had a higher level of salivary antibody, proportional in that cohort, that you didn't get seroconversion. So there was a direct relationship between the presence of salivary antibody and whether you seroconverted, and that was kind of suggestive that that was evidence of rapid clearance. And this was kind of backed up just recently, actually. A recent paper in Nature Biotechnology really did a series of experiments to show this. And what they found was that children actually had a very highly pre-activated immune state in their mucosal system, particularly with interferon response. And interferon is very, very important for viral clearance. Whereas the adults had a much poorer kind of interferon activation, okay, as a baseline status. And then exposure to the virus produced a much weaker kind of effect, which actually promoted survival of the virus and much more delayed clearance. And so this was kind of proof of, concept or validation of the early studies that we had published. That was kind of good to see that data coming through. Of course, we know that children and adults, through a number of other bits of data that have emerged, are very, very different. And I did talk about age-related effects. And what you can see here is that in a very kind of descriptive way, is that if you took a group of children who are SARS-CoV-2 positive or elderly patients who are SARS-CoV-2 positive, their immune profiles clustered very differently. You can see that they're separated very differently. And when you look at this on this graph on the right, this tells you what they're responding to. So the elderly patients are producing a very, very different profile of immune responses compared to the children. And I won't go into all of what these mean, but basically the child response is a much more specific and a much more targeted response to the virus compared to the adults. And that is further evidence for why children are able to rapidly clear the virus and therefore may have much less severe infections. Another aspect of the research that we were trying to do is understand duration of immunity. And this is very important to understand when someone might be exposed and susceptible to a virus or a reinfection, for example, and also has implications for vaccination. We want to know when we should be boosting. And that's kind of quite important at the moment because it seems like boosting is happening every 6 months. And we're not really entirely sure whether that is necessary across all age groups. It might be necessary for certain age groups. And we looked at this for our cohort, and this is a Wuhan cohort. And what we actually found was that if we just took children and adults who could produce antibody responses, they actually produce antibody responses in a very, very similar way. They're both in terms of magnitude and in terms of duration. And you can see here the seropositivity level over time by 6 months post-infection was actually identical. And so that's reassuring in some sense that the children can actually produce adequate immune responses and those immune responses do last. Yes. Okay, I'll continue. Okay. So we then went on to look at a bit more detailed analysis of the seroconversion in children and adults. And this was a paper that we recently published about a couple of months ago. And what we found was quite startling, actually, was that if we took all children in our cohort and all the adults in our cohort and looked at whether they seroconverted or not, so these are all individuals that had a PCR positive test, we found that only half the children seroconverted compared to adults, suggesting again that children might be clearing the virus more effectively and therefore not seroconverting. Of course, if you're not producing antibody, does that mean that you're at greater risk of a reinfection, for example? And that is a question that we still don't know. Interestingly, with our cohort, when we looked at CT value, remember CT value is a marker of how much virus is in your system. Most studies up until that point, until a point of our study anyway, showed that adults had a much higher viral load than children, which is why they produced much stronger antibody responses. But in our cohort, they were actually identical. They were very, very similar. So there was no difference in the amount of virus between children and adults, yet children somehow were not seroconverting. And that was of interest to us because we wanted to know what their risk was potentially down the track. We did some immune profiling, and this was done by flow cytometry, and I've just shown some of the data here, but we actually looked at lots of different cell populations, but these two are probably the most important. We looked at, on the left, we looked at antibody positive memory B cells. So we know that memory B cells are very important for long-term protection and antibody production. And on the right, we looked at CD4 T cells, particularly the effector memories, and these are critical in the response to an infection. In the orange coloured bars, these are the adult responses, and in the blue coloured bars are the children responses. And really what I want you to kind of get an idea of is the change in these populations. So in an adult, this one here, the most, I guess, the least coloured of the boxes, these are your kind of healthy controls. They're PCR negative and they're seronegative. So they're basically a healthy control. But as you have an infection and you develop antibodies, you have increasingly reduced numbers of B cells because those B cells are producing antibodies, so they're getting converted, which is a good sign of an infection response. But we don't see this in children. It's actually flat. There's been no change. And likewise with the T cells, the production of memory T cells increases from no infection to having an infection and producing antibody, which is on the right here. But again, the children actually had no change. And so this kind of added to that idea that maybe children who are not seroconverting may be more at risk because they're clearing the infection so efficiently, your immune system is not able to produce what we call an adaptive response. So that engages your T cells and your B cells. And that's where vaccination may be important to provide that added layer of protection. But somewhat reassuringly, so I should say that data that we published was based on Wuhan infection. And so this is unpublished data. It's quite new, but it's reassuring in a way because what we wanted to do is look at what's happening in our Delta wave and in our Omicron wave. And you can see the numbers here. For Omicron is relatively low because we're still recruiting. But what you see here is this is the data I've just shown where seropositivity was about half in the children compared to the adults. But for Delta and Omicron, actually we have 100% seropositivity. So all children and all adults are producing an antibody response. And that's probably a reflection of the virus itself. We know that those two variants are very different to Wuhan. When we look at absolute concentrations of antibody, we see that Wuhan and Delta are relatively similar. But for Omicron, although we have 100% seropositivity, actually children produce much lower levels. And so again, this does provide some reason for us to believe that children may produce a response, but whether that's going to last as long or be protective for as long is something that is currently being studied. And really just to kind of highlight this data, again, this is something really recent from Israel. It's actually a preprint, so it hasn't been peer reviewed. So that's important to acknowledge. But this is actually to show that in children, these are young children that had a Wuhan infection, their risk of reinfection during a Delta wave actually is still about 70% up to 1.5 years later. So that's actually very, very good, very reassuring. And actually 94% in the first 6 months. So we know that as antibody wanes, the duration of protection is going to wane, but actually it's still very, very high. And that suggests that a Wuhan infection will protect against Delta in some ways. Of course, we don't know anything about Omicron, as I mentioned, and that is, I guess, the next key piece of the puzzle. So in the last part of the talk, I just want to talk about the long-term complications of COVID in children, particularly MIS-C and long COVID. And for those that are not familiar, MIS-C is defined in the US as multi-system inflammatory syndrome in children. And it's really just a definition where a child has COVID infection, they recover in most cases, and then develop this severe manifestation some weeks later, and I've got here 2 to 6 weeks post-infection. It's where you have fever. It's a multi-system disorder, so more than 2 organ systems are involved. You have inflammation being documented, and you have to have a positive PCR or serology test. So we know that they have had COVID. It's important because even though it's rare, actually most children become hospitalised. And the clinical severity, at least at the moment, seems to be very similar across the variants. So variants haven't impacted on whether this becomes more serious. And this is just some data from Denmark, where you can see that the line here are the cases. And this is closely followed by these bars, which are the MIS-C cases. And so where you have a wave, you have a follow-up of MIS-C cases. And of course, here now with Omicron, you're seeing a very big increase in the number of MIS-C cases. This has also been shown in the US. And the US have much more detailed data because they've had far more number of cases. And the dotted line here are the number of cases in children. You have a big spike here with Omicron. And this is somewhat, we don't know yet, but we believe, because this data is until the end of May, we believe that this is going to be followed by a kind of sharp rise in cases due to Omicron. But their data suggests that the average age of MIS-C is about 9 years of age and mostly male. And there is a very strong, proportion that are related to ethnicity. We're trying to do some studies in some Asian countries, particularly in Vietnam, because we believe that this is definitely an underreported syndrome. And actually there are some anecdotal evidence that there is a high number of MIS-C cases as a result of Omicron. So this is something that needs to be, developed a bit more further. I did mention that despite these increased cases, it actually, in terms of MIS-C, it does appear that the risk, and this is from Israel, the risk of developing MIS-C is much lower. So for Alpha and Delta, there was about 40 to 50 cases per 100,000 developing MIS-C, but it's about 10-fold lower rate for Omicron. So that's actually quite reassuring because we know Omicron is generally a bit more milder and tends to infect the upper respiratory tract a little bit more commonly than other previous variants. There was lower ICU admissions and actually a lower requirement for treatment. So these are all indicators of a generally much more milder phenotype of MIS-C, which is actually pretty reassuring. What about long COVID? Long COVID is a big problem, and it's going to be a big problem over the next period with Omicron. And I think we're only really starting to understand what the biological basis of long COVID is. And this is really just to show the dynamics over the COVID infection. And we know that we have the acute COVID infection where we can detect the virus. But what happens when the virus disappears from the system? It can affect a lot of different organ systems. And this is what we call the post-acute COVID-19 syndrome. And this can actually last for weeks or months even. And you can see here lots of different organ systems occurring. And the most common ones we hear about are the neurological conditions and the vascular conditions. And really it's defined as having persistence of these symptoms for more than 4 weeks after the initial infection. So it's got to be at least 4 weeks. But as I said, it can last for many, many months. And this diagram really shows all the different organ systems that can be affected. Of course, studies in children are a lot more limited. And that's, I guess, what we're, more interested in for now, because children are kind of being infected at much higher rates than ever before. And some of the kind of manifestations you see here is that fatigue is by and large the most common, more than 90% of participants. Headache, loss of concentration, cardiovascular, gastrointestinal, and cough and sore throat. At least more than half of patients have experienced these symptoms for more than 4 weeks. Now, this study from Denmark really highlights the importance of proper long COVID studies, because what you really need to understand in terms of studies of long COVID is we need control groups, because what you see here is that these kind of symptoms in long COVID, such as concentration difficulties and fatigue, in the control group, they're already 20 or 30%. And when you look at the COVID infected group, they're actually the same, about 20 to 25%. So you cannot actually tell the difference between, based on those two symptoms, whether that is a true long COVID symptom. What does appear to be quite specific for COVID infection and long COVID symptoms are the loss of smell and the loss of taste, and potentially headache, although headache does appear to be common also in the control groups. And so in this study in Denmark, it was a very big study. We did see that the COVID positive children actually did report symptoms more frequently than the controls, but only about 0.8%. But in most cases, children with long COVID actually resolved within 1 to 5 months. So that's somewhat reassuring, but there still needs to be better data. In the UK, this is a study without a control group. And what you can see here is these red lines showing the persistence of symptoms for the first 28 days. And what you see here is that fatigue, of course, is the most common one. We know it's not a very good discriminator. Sore throat is a popular one. Headache, of course, which kind of disappears by day 28. But the loss of smell here seems to be persistent at least until day 28 in this study. And this one reported that, again, it was between 2020 and end of 2021, so very early in the pandemic, and about 4.5% had symptoms for more than 4 weeks, and about half of that had symptoms for more than 8 weeks. So really there's a lack of data on this area. Now, and just in the last couple of minutes, I just want to touch on vaccination, and because I think this is an important area. And what you see here is that this is just a snapshot of global vaccination across the world, across the regions, as you see in the colour. And what you see here is, in this last part of the graph, very, very low vaccine coverage. And this is primarily in the African nations. We know this is important because low vaccine coverage means variants, high circulation, high transmission, and high variants. So we do need to get vaccine equity up in these regions. In terms of complete COVID vaccination, I've just put Australian data here. As you can see, very, very high coverage in the older age groups. But for children, here at 12 to 15, it's about 80%. This is not the booster dose regime. This is just 2-dose primary series for children, because booster doses are not always recommended for healthy children. In 5 to 11 years, of course, we have no vaccination because at the time of this data, that vaccine was not approved in that age group. And we know that uptake is actually quite low in young children for various reasons. This is probably the most recent study in children showing Moderna vaccination. This is in US children, comparing young children 6 to 11 years of age and older age groups, basically showing that getting very, very good antibody responses, very similar kind of antibody responses, and very, very high seropositivity, 99%, which is great. Noting that in children, it's half the dose that what an adults get. And that's because an mRNA vaccine is highly reactogenic. And so we have to drop the dose for children because they tend to react more seriously to the vaccine. In terms of effectiveness against symptomatic disease, we know that the vaccine was highly effective in this study, about 92% vaccine efficacy. So we do have confidence in these vaccines, particularly for children, but we just need a bit more communication around the benefits of vaccinating children. This is a bit of a simulation to show that what would happen if we had an emergence of a new variant and whether we had vaccination or no vaccination. And what you can see here is in the blue lines, if there was no new variant, actually vaccinating children would have no real benefit. Things stayed the way they are, there's no real benefit of actually vaccinating kids. But if there is a new variant emerging, and I'm talking about now things like the BA4, BA5 subvariant, you actually see that the benefit of childhood vaccination, which is this sort of lighter orange line, will lead to reduction in cases and hospitalizations in this case. So there is a clear benefit depending on the setting, and I think we need to be kind of thinking about that and being prepared as a sort of a global community. So the big question really, and I'll kind of finish with this, is should we vaccinate children? And I guess there's no real answer to this. I think it depends on the setting. but there are lots of different arguments for and against. I won't go through them all, but of course, they're pretty obvious: protecting against disease, protecting against severe disease and the manifestations of long COVID, etc. Against, of course, we know that it's generally mild in children, so why would you want to vaccinate children if it's a relatively mild disease? Of course, we don't know the long-term effects of those illnesses, and there's lots of other things that might prioritise whether we should vaccinate children or vaccinate other communities before we vaccinate children. So this is an ongoing debate. So just to summarise, children still remain low risk of severe disease following COVID-19. And this is really even in spite of these increased cases from Omicron. Children do have more robust immune responses that appear to protect them against severe COVID-19, and that's a good thing. But we know that severe manifestations do occur, MIS-C being one of them, but still rare, even in the current setting of Omicron variants. We certainly need more research to understand long COVID in children. This is a very understudied area, as is just COVID-19 in children in general. And of course, the long-term impacts, what we call the indirect impacts of the pandemic on children, such as education, social, mental health aspects, it's really going to be a big issue in the coming months and years. And I think vaccination definitely is going to benefit children, but we do need better communication, I think, particularly around the benefit risk profile. And that's really dependent on each community. So I think I'll leave it there. I just want to thank, there's lots of people in my group that have been responsible for the work. I've got them here at the bottom here. They've done a lot of the data that I presented earlier. The clinical team at the hospital. And I think I'll leave it there, and thanks for your attention, and happy to answer any questions. Thank you.
Thank you, Dr. Paul. Very good presentation. Thank you. As a parent myself, I think it's a very good insight. COVID in children. Do we have any questions from the floor? From the participants? Please raise your hand if you have any, or you can type it in the chat box.
Hi, Paul. Fazila
Hi.
here.
Hi.
I would like to ask two questions. Thank you for an insightful talk. It is very interesting. For the first question, I would like to ask with regards to the when you state that there is effectively or efficient clearing of the SARS-CoV-2 virus in the saliva due to the presence of the IgA in the children. In which group of children? Is it 5 years or below, or 5 years to 11 years old, or something like that? And the other question is, it is exciting to know when BCG vaccination have some kind of protection mechanism towards SARS-CoV-2. And in Malaysia, the vaccination program or immunization program in our country, all the children is compulsory to be vaccinated by the BCG. So it is quite an interesting or innovation kind of thing if we got to know the maybe we can have the opportunity to repurposing our BCG to fight or combat the COVID-19. So what could you please enlighten us? How does the BCG for the tuberculosis can act, or can give us some insight towards the protective mechanism against COVID-19? Thank you.
Yeah, thank you for those questions. I can answer. I'll start for the first one. So in terms of the mucosal antibody response in children, I think in our study what we found was that it kind of, the pattern was similar whether you're a young child, say under 5, or older child. Of course, we do know that the younger you are, the more robust your immune system is, and more kind of activated and what we say primed. It can respond much more effectively. So I do think that more studies in young children definitely would show, I guess, an enhanced capacity to respond to the virus and clear it. And the question around BCG, yeah, this is very, very interesting. As I mentioned, there are a number of studies looking at BCG in adults, and I know where we are at MCRI, there is a large kind of multi-site study to do that again in healthcare workers, because healthcare workers are, one of the kind of high exposure groups. In terms of the way it works, yeah, it works by a mechanism known as trained immunity, and I mentioned that before. Basically, what the hypothesis is, and I should say BCG has been very, very well studied for trained immunity, but not in the context of COVID. So it has been shown that BCG can induce certain changes in innate cells at the molecular level, at the epigenetic level. And those changes actually make those innate cells like monocytes and so forth have an increased capacity to respond to other pathogens. We're still kind of trying to understand exactly how this works, but there are lots of studies that show that if you give BCG vaccination, you'll actually find that in the first few weeks after that vaccination, you have a reduced all-cause mortality in children from things other than TB. So it's actually quite exciting. We're still waiting on the data in relation to COVID-19. So I think, I guess that's a wait and see. But yeah, it definitely in terms of repurposing could provide a good, a good option for countries that are unable to access the current COVID-19 vaccines for different reasons. So I think it's definitely an option that we should be considering. Thanks.
There is a question in the chat box from Associate Professor Dr. Anisi Ham. Is there a correlation between the quantitative level of antibodies with clinical disease, especially in MSC patients, both in vaccinated or non-vaccinated group of children?
Yeah, so I guess if we just took unvaccinated children, then what you tend to find is the more severe the illness, the more antibody response that you get. And originally that was shown particularly in adults, because adults had more severe disease in general. But I think what you'll find is, particularly with MIS-C, you actually get a much more significant antibody response. So the quantitative level of those antibodies are much higher than in children, for example, that don't get MIS-C. In the context of vaccination, I think vaccination has been shown to protect against MIS-C in some capacity, not 100% effectiveness, of course. So I think the antibody response is kind of like a double-edged sword in a way. So you can have the antibodies prior to the development of COVID. Okay, so that induced by vaccination would protect and therefore protect MIS-C. But of course, if you have lots of antibody as a result of the infection, because in some cases, particularly in immunocompromised children, for example, where they aren't able to control the virus in the same way, they actually might have a much more robust inflammatory response and therefore antibodies. So the studies of vaccinated kids and MIS-C, I guess, is probably more limited, mainly because MIS-C is prevented in some way by the vaccine.
Hope that answers your question, Rob. Another question from Ernie. Why is it at the beginning of the COVID outbreak, children are said to be less affected? By now, we see more children are more severely affected.
Yeah, so this is the worrying trend at the moment, and we're seeing this predominantly in Europe. And I think this is to do with the new subvariants. I kind of alluded to it in the talk, you know, Australia and many other parts of the world, we haven't actually seen much of these BA4 or BA5 subvariants. In Europe, it's almost 100% in some places. And we know that those subvariants are actually very, very different. They evade your immunity that you've developed in relation to vaccination, but also in relation to prior infection. So it's a very unique subvariant. It kind of appears at a different kind of lineage. And that is kind of the worry that I was mentioning, that, you know, if we do see a rapid increase of those sublineage variants in our communities, we are going to be faced with an increase in cases in children, but also in adults. So I think it does make us think about what we should be doing in terms of vaccination. And we know that current vaccines seem to be holding up relatively well against severe disease, but I think there now is a very big push for these new generation vaccines, so-called Omicron variant vaccines and other multivalent vaccines. So we hope in the next 6 months or so that those vaccines will start to come online, because I think we could be in a bit of trouble with this variant if it reaches us.
Thanks, Paul. Yeah, there's another question for you. Hi, Dr. Paul, a very nice and good presentation. Is there effective ways to improve nasal immunity, especially among children?
Sorry, you mean improving mucosal immunity? Is that what you said?
The question says nasal immunity.
Nasal immunity.
Probably mucosal immunity.
Yeah, that's an interesting point. It's a good point, because I think there are actually mucosal vaccines being developed. And so I think the idea is that, of course, you want to target the site of infection. Of course, mucosal vaccines are quite challenging. You know, we haven't really been able to develop any kind of effective mucosal vaccines really up until this point. And so, but what I hear is that the COVID vaccine, the kind of so-called nasal sprays, there are some nasal spray treatments as well that are apparently quite effective. So it's a bit of a wait and see. They're very early days, but I think anything that you can do that can promote mucosal immunity is going to have quite a substantial effect.
Any more questions from the floor? Don't see any in the chat box. Right, Paul, I have a question. I've been reading on this hepatitis of unknown origin among children infected with COVID and associated with adenovirus type 41. Has there been any studies that actually associate them to SARS-CoV? Is it a long COVID effect? Or?
Yeah, this is quite interesting. It was obviously, it seems to have kind of petered out a little bit. I think that the cases certainly seem to be more associated with adenovirus, a very particular adenovirus, more than COVID. But of course, I think in many parts of the world, this hasn't kind of been captured as well. And I know there's some people where I work that are kind of interested in this. We know that there is a strong gastrointestinal involvement with this kind of syndrome, and in some people, particularly children, they do have a lot of prolonged viral shedding in the gastrointestinal tract, and so this could be a reservoir. So I think it's one of those things that we don't really understand. I think people kind of don't really want to, deal with the idea that it could be a COVID thing. I think it seems to be more associated with an adeno or a situation where you might have a co-infection that's kind of reactivating the virus. But there is definitely a big push to understand this, and I think one way is to get proper samples, which has often been difficult to get those samples. So I actually haven't heard too much about that recently, but of course, couple of months ago, it was very, very big news. And, so I think everyone now is talking about monkeypox. So I think, you know, I guess we'll see what happens.
Right, thank you. Do you have anyone has got any more questions? You can just raise your hand or speak. If you want us to read your questions in the chat box, could you please type it there? All participants, please take note that the attendance link is provided in the chat box. Right, one last question. For me, seeing that the children does not seroconvert, what do you think is the status of their vaccination? Will they have to be vaccinated as their antibodies wean out every coming months? I'm not too sure.
Yeah, I think. Yeah, this is one of the key questions. You know, how often that you should. Well, after the primary series, how often should you vaccinate? So I think in otherwise healthy children, you know, immunocompromised, those kind of groups, maybe the kind of thinking is that maybe they only need to be vaccinated every 12 months.
Every 12 months.
Yeah, every 12 months. Of course, a lot will be dependent on what emerges, you know, in the pandemic. But at the moment, it seems like that's the current thinking. Many children are not getting vaccinated, actually, you know, or certainly not getting boosted. So that's something that we just need to kind of watch and wait and see how that affects, you know, in terms of what happens with the pandemic. Because I think if we do get these variants or other variants, that could change the thinking. So we know that immune responses do persist. So even in children that do produce an antibody response, they will persist for at least 6 months or longer. We know that protection is not just antibody driven. So protection is also mediated by cells like T cells. And we know the T cells are relatively consistent and stable, actually, right across those few months. So I think definitely frequent boosting is probably not necessary. And I would say, yeah, 12 months, every 12 months is probably the minimum.
Thank you very much, Associate Professor Dr. Paul. I don't see any more questions. One last call if anybody has got any burning questions for Dr. Paul from Melbourne.
How safe is the vaccine in children?
Sorry, was that how safe the vaccine is in children?
Yeah, how safe are the vaccines in young children, especially in young children, 6 months?
Yeah, I think that, I mean, that's the really kind of critical point. There's been a lot of work around the safety, and I did mention that in that particular study that was slightly older children, particularly the mRNA vaccines, they're the only ones at the moment that are kind of being approved for young children. But the dose of the mRNA vaccines is very strongly linked to reactogenicity. So if you remember, there was a lot of reports of myocarditis and pericarditis. They've dropped the doses in those young groups while still maintaining its immunogenicity and efficacy. But I think they're otherwise safe as far as we can tell, but I don't think there has been the amount of studies done at the moment, particularly in those young age groups that we probably need. So vaccine confidence is a big issue, and I think more studies to show that they're safe will go a long way to help that.
With this, I think I will conclude the webinar series for today. Thank you very much for all who participated. See you all for the next webinar series. Thank you, Dr. Paul, for your time. I believe
Thanks
it's
very
about
much.
4:30
Thank
now,
you.
about 5.
Thanks.
Yeah.
Thank
you very
you.
much.
Thanks very much. Pleasure. Thank you.